I appreciate the opportunity from the Scientific Program Committee to present this video on posterior options for C1-2 fixation. Some of the indications for C1-2 fixation are trauma, atlantoaxial instability and rheumatoid arthritis, tumors, or chronic pathology such as odontoideum, which create instability at the C1-2 junction. The techniques that we're going to go through at this stage are C1 lateral mass screw fixation, and then a variety of C2 fixation techniques, such as the C2 pedicle, the C2 pars, and the C2 translaminar screws to make segmental fixation at the C1-2 junction. This was initially described by Dr. Goel, where he used segmental fixation for C1 and C2, and then was further refined with the screw rod systems by Dr. Harms and further popularized by Dr. Harms. So what we're going to primarily concentrate on is the C1 lateral mass and C2 pedicle technique. As you can see from the X's on the diagram on the right, these are the areas of entry for a C1 lateral mass screw, which is at the junction of the arch and the lateral mass. I feel this by palpating down the arch of C1 into the lateral mass. Obviously, you don't want to be too lateral because you could be in the vertebral artery. The C2 pedicle entry point is in the upper medial portion of the isthmus of the pars, as seen by the lower X on the C2 vertebra. We use fluoroscopy primarily to provide our trajectory. In the axial plane, we are straight or slightly convergent about 5 to 10 degrees. And then in the sagittal plane, we are parallel to the arch, aiming towards the anterior arch of C1, as seen on this radiograph superiorly on the right-hand side of the diagram. The potential errors for creating a C1 trajectory are that you can be too medial, which will give you an ineffective screw, though you could be too medial and injure the spinal cord. But then the thing you really have to avoid is the lateral trajectory, which could obviously interfere with the vertebral artery. And you want to be, again, straight or slightly convergent, as seen with the blue arrow in the middle. Again, the aiming point for the C1 lateral mass screw is the mid to inferior portion of the anterior arch of C1, as seen with this yellow arrow. What we do is then start with the notching technique, and then we'll start to drill to 10 millimeters, 14 millimeters, 18 millimeters, and then through the anterior cortex by 2 millimeters, usually to 20 or 22 millimeters. But we go very slowly and palpate after each drill advancement to make sure we haven't gone too far through the anterior cortex, as you can see here in the axial and sagittal planes. Again, the C1 lateral mass is very carefully started by using a notching technique underneath the C1 lateral mass. The C2 nerve root is pushed inferiorly or cut. We'll get into more of this later. And the C1 lateral mass screw is on purpose lengthy to sit superficial, so it is not compressing the C2 nerve root. Whether you use a unicortical or bicortical fixation depends on how the quality of the bone is and how much manipulation you're going to do with the C1 lateral masses and the C1 vertebral arch. I tend to prefer a unicortical technique, but do go as far as bicortical with drilling occasionally. Whether we transect the C2 nerve root or not is up to debate, and it very much depends on your personal preference. This is a meta-analysis from the group in Toronto, which shows that basically there is no difference in occipital neuralgia whether you go ahead and transect the nerve or whether you go ahead and preserve the nerve root. Obviously, transection leads to more occipital numbness, but actually transection leads to a lower blood loss and a shorter operative time in this meta-analysis, as seen on these forest plots on the left-hand side. Again, you can use segmental fixation to go ahead and take care of a variety of pathologies. This is someone who had a free-floating lateral mass on the right-hand side that had been treated in a halo for over 6 months with absolutely no healing of the lateral mass. What we went ahead and did was do a C1-2 fixation because we thought direct osteosynthesis 6 months out would not work. So we went ahead and did a C1-2 fusion. And you can see we can place our lateral mass screws where they need to be within the lateral masses, no matter how displaced they are. For segmental fixation, we will need to achieve fixation in C2, and there are a number of possible trajectories. There's the C2 pars screw, as seen in the green screw trajectory, the C2 pedicle, as seen in the orange trajectory, and the C2 translaminar screw, as seen in the blue trajectory. It is important to note that a C1 lateral mass screw and a C2 translaminar screw has less stiffness than transarticular screws or C1 lateral mass and C2 pedicle screws, but there's still adequate stiffness to achieve fixation and fusion in these cases where the vertebral artery anatomy is not accessible for C2 pedicle screw. Again, we have to differentiate between a pars screw and a pedicle screw. This is a parasagittal image showing the upper K-wire inserting where you would insert a C2 pedicle screw, and then the lower K-wire is where you would insert a C2 pars screw, much along the trajectory of a C1-2 transarticular screw, but much shorter, obviously, than this. What you're trying to do with the pars screw is place the screw, as seen in the red arrow here, between the superior articular process and the inferior articular process is where the pars is of C2. The pedicle is obviously more medial, so this is the K-wire trajectory that you can see here, where you want to go ahead and actually progress superiorly and medially along the pedicle of C2. The C2 pedicle screw has been suggested at a variety of angles. What I will usually do is go 20 to 30 degrees medially and 20 to 30 degrees cranially and aim for the base of the dens on a sagittal X-ray to progress with the C2 pedicle screw. This is seen on the axial CT images here, where you can see the screw actually progressing cranially and medially along the pars of C2 to provide good fixation. And this is what it looks like on a sagittal CT on the right-hand side. There is the popular misconception that pedicle screws are safer, but Dan Resnick did a particular study that looked and found that 8 to 9% of patients are not candidates for pedicle screw placement either, and found that only 4% of patients are not candidate for either a pedicle or a pars interarticularis screw. That leads us to the pars screw, which is sometimes necessary if you have a high riding vert. You can see that on these images here, where actually the C2 vertebral body was removed and we placed a pars screw to achieve fixation at C2. We usually use a 14 to 18 millimeter screw, and again, the entry point is similar to a transarticular screw. Whether you use a pars screw or a pedicle screw really is a trade-off of safety versus rigidity. There is a higher incidence of vertebral artery injury with pedicle screws than there is with pars screws. There is radiographic screw malposition with either of these techniques, and the fusion rate is slightly higher with a pedicle screw, but it is not statistically significant than the fusion rate you see with the pars. Greater than a 90% fusion rate is seen with either technique, suggesting that this segmental fixation is very effective in achieving fixation. The nice thing about segmental fixation at C1 and C2 is that you can actually reduce fractures that are translated and chronically will not reduce, such as seen in this chronic C2 fracture in a young man. What we have to also remember is that we can use a translaminar screw if we're worried about the anatomy of the pars. The trajectory is seen here as in the red and blue arrows, where you go down the lamina of C2, and you can see where the final trajectory is here on the axial CT images. I usually use a 24 to 28 millimeter screw for a translaminar screw. Biomechanically, the pedicle screw has the strongest pullout strength, and the translaminar screw has an intermediate pullout strength compared to the pars screw. But the pars fixation is actually better than the interlaminar fixation in an unstable model, particularly in lateral bending. So I think of the laminar screw and the pars screw as equivalent in terms of strength, but depending on whether you have the proper anatomy, you can use either one. Now remember, the goal of any surgery is to achieve fusion, and you can use a variety of techniques to do this. You can see the far left construct uses pars screws at C2. The intermediate X-rays show pedicle screws next. You could use a combination of a pars screw and a pedicle screw as seen here. And then if you're worried about the vertebral artery anatomy, use a translaminar screw. But remember, you can't use the onlay graft. When you use this technique, you have to get graft into the C1-2 facet joint to do this. Like transarticular screws, there are complications that you need to notify the patient about preoperatively. The vertebral artery injury is the thing we worry about the most. In the old literature with transarticular screws, the vertebral artery injury was about 4.1% per patient. This is lower with C2 pars and pedicle screws. Remember, you have to have a CT scan to really define the anatomy of the vertebral artery before you proceed with this. There's always the worry of non-union, dural tears, suboccipital neuralgia, and then hardware failure, which could lead to non-union. So in summary, what we found is that there are a variety of techniques available for C1-2 fixation. C1-2 segmental fixation is a certain advancement over C1-2 transarticular screws, but you need to have preoperative CT to assess the anatomy. Vertebral artery injury is still possible even with all these techniques, and you need to have a strategy to learn how to deal with it. Remember that these segmental fusion techniques have consistently shown a greater than 90% fusion rate, but you still have to think about how you actually proceed with the fusion if you're not dealing with osteosynthesis of an acute fracture. Thank you for your attention.